Okay, let's unpack this. You flagged your rheumatic fever notes as high priority for your MSRA prep, and that's exactly where we're going to dive in today.
Yeah, okay.
Our mission is basically to extract the core exam essential information. No fluff, just the critical details you really need to know.
Absolutely. And it's interesting, isn't it, how it's become quite rare now in many places.
Right. That's what I found fascinating. A serious condition, but much less common in developed countries now. As future clinicians, that shift itself, well, it holds some important lessons.
It really does. It's a powerful example of public health, access to health care, how things can change. So shall we start at the basics? What actually is rheumatic fever?
Yeah, lay it on us.
Okay. So rheumatic fever is a chronic systemic inflammatory disease.
Mm.
But the key thing, it doesn't just happen on its own. It's what we call a sequela.
A sequel, meaning it follows something else.
Exactly. It follows a Group A beta hemolytic streptococcus infection, you know, GAS.
Yeah.
The bacteria that commonly causes strep throat, pharyngitis,
Ah, strep throat, right.
usually about 2 to 4 weeks after that initial sore throat. Sometimes, though, maybe in hotter climates, it can follow a strep skin infection too.
Okay, so the strep bacteria triggers it, but it's not the infection itself causing the main symptoms.
Precisely. The strep throat is the trigger.
Mhm.
But rheumatic fever itself is this systemic inflammatory response. The underlying problem is actually vasculitis.
Vasculitis, inflammation of blood vessels.
Yeah. And because it's systemic, that inflammation can affect various parts of the body. We worry most about the heart, obviously, but also joints, the brain, even the skin.
And the heart damage, that's the really long-term concern.
That's the one. Rheumatic heart disease. That's the permanent damage to the heart valves that can result.
Yeah.
And that's why it's so significant.
Okay, so who's more likely to get this after a strep infection? What are the risk factors we should know?
Well, there are a few layers to that. Social factors definitely play a big role. Things like poor housing, overcrowding.
Which helps strep spread more easily, I suppose.
Exactly. And also low socioeconomic status, which often means limited access to health care, maybe not getting antibiotics quickly for strep throat. Climate also plays a part.
Right, you mentioned skin infections in warmer climates, but typically more common in winter?
Typically follows pharyngitis, which is more common in winter, yeah.
And what about biological factors? Anything there?
Yep, we tend to see it more often in females, and particularly in children aged between 5 and 15 years old.
Okay, 5 to 15. Prime age group.
And there seems to be a genetic component, too. Some studies, like twin studies, suggest a predisposition. We also see higher rates in certain populations, like indigenous groups in Australia and New Zealand.
Interesting. And, of course, having had strep before.
Definitely. Previous GAS infection is a risk factor. And even the specific virulence, the nastiness of the particular strep strain can influence the risk.
Right. Okay, so let's picture this. A young patient, maybe 10 years old, had a bad sore throat a few weeks ago. Now they're unwell again. What are the red flags? What makes us think, hang on, could this be rheumatic fever?
This is where the diagnostic criteria come in. The modified Duckett-Jones criteria are absolutely key. They were updated in 2015.
Duckett-Jones. Okay, exam gold right here.
Absolutely. So first, you need evidence of a recent strep infection. That could be maybe a positive throat swab from when they were ill, although often that's negative by this point.
Its time has passed.
Or a history of scarlet fever, which is caused by strep. Or, crucially, blood tests showing raised antibody titers like ASO or anti-DNase B.
Those antibody levels, got it.
So you need that evidence of strep, plus a specific combination of clinical findings, either 2 major criteria or 1 major criterion and 2 minor criteria.
2 major, or 1 major plus 2 minor.
Yes.
How do we remember those major criteria? They seem important.
They are. There's a handy mnemonic,
Ah.
J0XCEDXB9Ps. Think of the word Jones, but with a heart symbol for the O.
J0XC80B9Ps. Okay, let's break that down. J.
J is for joints, specifically polyarthritis. This affects about 80% of patients.
Polyarthritis, multiple joints. What's characteristic about it?
It's typically flitting or migratory. So it moves from one large joint to another, knees, elbows, wrists, ankles.
Moves around, okay.
The joint will be warm, red, swollen, painful, difficult to move. But here's a key thing. The pain usually responds really well to NSAIDs.
Ah, good response to NSAIDs. That's helpful.
And it doesn't stick around in one joint for long, maybe hours to a few days, then it moves on.
Got it. Okay, next in GLRXC80AAB9 PTs is the O, which you said is like a heart symbol.
Exactly. Oh, my heart for carditis. Inflammation of the heart. This is the big one in terms of long-term consequences.
Yeah, this sounds serious. How common is it?
Happens in about 40 to 50% of cases. And it can be pancarditis, meaning it affects all layers, the pericardium, the myocardium, and the endocardium, especially the valves.
Pancarditis, all layers. Which valves are most often affected?
Primarily the mitral valve, that's involved in maybe 70% of carditis cases,
Yeah.
and the aortic valve, around 25%.
Mitral, then aortic, and we might hear murmurs.
Definitely. You need to listen carefully. Murmurs like the Austin Flint murmur that suggests severe aortic regurgitation, or the Kerry-Coombs murmur, sometimes heard with mitral valve inflammation. Carditis can also lead to arrhythmias or even heart failure.
Wow. Okay, so carditis is a major concern. What's next? N in JOXC80XB9PEs.
N is for nodules, subcutaneous nodules. These are seen in about 10% of cases.
Subcutaneous, under the skin. What are they like?
They're usually firm, painless lumps, maybe pea-sized. You find them typically over bony prominences or extensor surfaces, elbows, knees, ankles, sometimes the scalp or spine.
Painless nodules, and they tend to appear a bit later.
Yeah, often 2-3 weeks after the fever starts, and they're often associated with having more severe carditis.
Okay, good link to remember, E.
E is for erythema marginatum. This one's quite rare, maybe 5% of cases.
Erythema marginatum, what does that look like?
It's a distinctive rash. Pink, macular, so flat, usually on the trunk and the proximal parts of the limbs. Importantly, never on the face.
Not on the face, okay.
It can look a bit like a map with reddish edges and pale centers, and it might become more obvious with heat, like after a warm bath.
Map-like rash, worse with heat. Got it. And the final major criterion, S.
S is for Sydenham's chorea, also known as St. Vitus's dance.
Ah, I've heard of that.
Affects maybe 10–30% of patients, and interestingly, is more common in girls, often around 7 to 12 years old. It's also a late sign.
Late? How late?
Can appear 2 to 6 months after the strep infection. It involves these rapid, jerky, involuntary movements. They look sort of semi-purposeful. Mostly affects the face and upper limbs.
Jerky movements. And a key diagnostic point.
They stop during sleep. That's important.
Right. Chorea stops during sleep. Okay, so that's J0XC80SB9Es. Joints, polyarthritis, my heart, carditis, nodules, erythema marginatum, Sydenham's chorea. Phew, locked in. Now, the minor criteria.
Yep. For the minor criteria, you can think FEPAR, though sometimes the R is implied.
FEPA. Okay, what does that stand for?
F is for fever. Usually quite high, maybe over 39 degrees Celsius, lasting at least a week initially. Though, interestingly, patients with pure chorea might not have a fever.
Okay, fever. E?
E is for ECG changes, specifically a prolonged PR interval. But there's a catch.
Ah, always a catch.
You can't count this as a minor criterion if carditis is already one of your major criteria, because the ECG changes might just be part of the carditis.
Makes sense. Okay, P.
P is for previous history of rheumatic fever. If they've had it before, that counts as a minor criterion for a new episode.
Right, A.
A is for arthralgia. That's joint pain, but without the objective swelling and redness you see in arthritis.
So pain, but not the full inflammation picture.
Exactly. And again, there's a rule.
Yeah.
You can't count arthralgia as minor if polyarthritis is already one of your major criteria.
Right, avoid double dipping. And the R in FEPAR.
R is for raised inflammatory markers. So looking at blood tests, an elevated ESR, or erythrocyte sedimentation rate, or CRP, C-reactive protein, these are usually high.
Okay, FEPAR. Fever, ECG, prolonged PR, previous RF, arthralgia, raised inflammatory markers.
Got it. So besides these criteria, any other common signs?
Yeah, patients often report that recent sore throat, obviously. Also general malaise, feeling unwell, maybe shortness of breath or chest pain if there's carditis, sometimes palpitations, abdominal pain, even nosebleeds.
And on examination, hearing a new heart murmur should definitely raise suspicion.
Absolutely. A new murmur, especially in a child or young adult in that risk group, is a major red flag.
Okay, so we suspect it based on the clinical picture and the Jones criteria. What investigations do we actually do to confirm?
Well, as we said, the throat swab for strep might be negative by this stage. Rapid strep antigen tests can also have false negatives.
So swabs aren't always helpful later on.
Not always definitive, no. Blood tests are key. You'll look for that raised white cell count, the high ESR and CRP we mentioned in the minor criteria.
Inflammatory markers?
Troponin levels might be raised if there's myocarditis, inflammation of the heart muscle. And crucially, those antibody titers, ASO and antidinase B. Right, the evidence of recent strep. But you said they take time.
They do. They take time to rise after the infection, so you might need to repeat them after a couple of weeks if the initial ones are normal, but you still have high suspicion.
Okay, repeat titers might be needed. What about imaging or other tests?
An ECG is important. It can show that prolonged PR interval we talked about, or tachycardia, other arrhythmias. If there's pericarditis, you might see ST elevation or PR depression.
ECG for heart rhythm and inflammation signs. Chest x-ray.
A chest X-ray might show signs of heart failure, like cardiomegaly or pulmonary edema, if the carditis is severe.
Okay. And the really key investigation for the heart?
Doppler echocardiography. That's absolutely crucial. It allows us to directly visualize the heart, detect carditis, assess valve function, especially looking for regurgitation or inflammation of the mitral and aortic valves. It can also show a pericardial effusion.
Echo is essential for carditis assessment. Makes sense. Okay, diagnosis is made using the Duckett-Jones criterion investigations. How do we manage it?
Right. The main aims are threefold: supportive care, eradicating any residual strep infection, and reducing the inflammation.
Support, eradicate, reduce inflammation. Okay, how do we do that?
Initially, bed rest is often recommended, especially if there's active carditis. Strict rest until those inflammatory markers start to normalize. For severe arthritis, sometimes immobilizing the joint can help with pain.
Rest is important, especially for the heart. Then medications.
Yes, antibiotics are essential to get rid of any lingering Group A strep. Penicillin is the drug of choice, often given as IV benzyl penicillin initially if they're quite unwell, then followed by a 10-day course of oral penicillin V.
Penicillin to kill the strep. What if they're allergic?
Good question. Alternatives include macrolides like erythromycin or azithromycin. Oral clindamycin is another option.
Okay, and for the inflammation?
High-dose aspirin is the mainstay for reducing inflammation and controlling the fever and joint pain. You do need to monitor for side effects in children, like Reye syndrome, though it's rare, and also tinnitus or acidosis with high doses.
High-dose aspirin. What if that's not enough, or the carditis is bad?
Then corticosteroids like prednisolone are used, usually reserved for moderate to severe carditis or if the fever and inflammation aren't settling with aspirin.
Steroids for severe cases. Got it. What about complications like heart failure?
If heart failure develops due to carditis, it's managed with standard treatments, ACE inhibitors, diuretics. If there's a large pericardial effusion causing tamponade, where the fluid compresses the heart, that might require pericardiocentesis draining the fluid.
Okay. And the chorea, those movements.
The chorea can be quite distressing. Medications like diazepam or sometimes haloperidol can be used to help control the movements. Diazepam often preferred as it has fewer extrapyramidal side effects.
Right. Any role for surgery?
Primarily for complications, pericardiocentesis for tamponade, as I mentioned. And then later on, if there's severe irreversible valve damage from rheumatic heart disease, valve replacement surgery might be needed. Mitral valve replacement is the most common.
Valve surgery for long-term damage.
Okay. Now, a really crucial part seems to be preventing it from happening again, secondary prevention.
Absolutely vital, because having rheumatic fever once significantly increases the risk of getting it again if you get another strep infection, and recurrent attacks tend to cause more heart damage.
So how do we prevent recurrences?
Long-term antibiotic prophylaxis is the key. This means taking antibiotics continuously for many years to prevent new strep infections.
Long-term antibiotics, what's typically used?
The preferred regimen is usually intramuscular injections of benzathine penicillin G given every 4 weeks. It's effective because compliance is easier to monitor than with daily pills.
The IM injection every month. Are there oral options?
Yes, daily oral penicillin V is an alternative but relies heavily on the patient taking it every day. For penicillin-allergic patients, oral erythromycin or azithromycin can be used.
And how long does this prophylaxis need to continue?
That depends on the severity of their initial rheumatic fever and whether they have residual heart disease.
Okay, it varies. Yeah. If they had rheumatic fever without any carditis, it's usually for at least 5 years after the last attack, or until they turn 21, whichever is longer.
5 years or age 21 if no carditis. What if there was carditis?
If they had carditis but no persistent valve disease afterwards, then it's typically for 10 years or until age 21, whichever is longer.
10 years or age 21 if carditis resolved, and if they have ongoing valve problems.
If they have persistent valvular heart disease after carditis, then the recommendation is often for much longer prophylaxis, potentially lifelong, or at least until age 40.
Lifelong or until 40 for persistent valve disease. That's a serious commitment.
It is, but it's crucial for preventing further heart damage. And one related point previously, people with rheumatic heart disease were often given antibiotics before dental procedures to prevent infective endocarditis.
Ah, yes, i.e. prophylaxis.
Current guidelines, certainly in the UK and many other places, generally no longer recommend routine antibiotic prophylaxis solely based on a history of rheumatic fever or rheumatic heart disease for preventing, i.e. during dental or surgical procedures. The focus is now much more on maintaining good oral hygiene.
That's a significant change. Good to know. Okay, what are the main long-term complications we really need to be aware of from rheumatic fever?
The biggest one, as we've discussed, is rheumatic heart disease, RHD. The risk is significant, maybe over 50% after an episode of RF with carditis.
RHD, and that manifests mainly as valve problems.
Yes, valve abnormalities are the hallmark. Most commonly, it affects the mitral valve, leading to mitral stenosis, a narrowing of the valve or mitral regurgitation leakage. Often it starts as regurgitation during the acute phase and can develop into stenosis years later.
Mitral valve stenosis and regurgitation, most common.
Yeah, involved in 90–95% of RHD cases. The aortic valve is the next most common, affected in maybe 20–25%, again causing stenosis or regurgitation. Tricuspid and pulmonary valve involvement is much rarer.
Okay, primarily mitral and aortic valve disease. Any other complications?
Well, the carditis itself can lead to chronic heart failure. Pericardial effusions can occur. Arrhythmias, especially atrial fibrillation, can develop later on, often related to the valve disease and atrial enlargement. Pulmonary hypertension can also be a consequence of long-standing mitral valve disease. There's also something called post-streptococcal reactive arthritis, which is similar but doesn't meet full criteria for RF.
So, a whole range of potential cardiac consequences. What's the overall prognosis like?
It really varies. Unfortunately, rheumatic fever can cause irreversible heart damage in about 30% of patients after a first attack. Recurrences are possible, especially within the first 5 years.
And survival.
Survival depends heavily on the presence and severity of heart disease. If someone has RHD but is asymptomatic, the 10-year survival might be around 80%. But if they have significant symptoms, it could be as low as 15%.
Wow, that's a stark difference.
Most episodes of acute rheumatic fever improve within about 12 weeks, although the chorea can sometimes persist for months or even rarely years, and things like pregnancy or starting oral contraceptives can potentially increase the recurrence risk in women with a history.
So, ongoing vigilance is needed. Any new sore throat in someone with a history?
Needs prompt medical review and likely treatment, absolutely.
Okay, so wrapping this up, what does this all mean for you prepping for the MSRA? Clearly, understanding the Deca-Jones criteria is paramount.
Definitely. Knowing those major and minor criteria is key.
Remember J0XC80XB9Es for major joints, oh my heart, carditis, nodules, erythema marginatum, Sydenham's chorea, and FIPAR for minor, FEV, ECG changes, previous RF, arthralgia, raised inflammatory markers, nail those down.
And understanding the key signs and symptoms associated with each, like the migratory nature of the arthritis or the features of chorea.
Plus the principles of management, eradicating strep with penicillin, managing inflammation with aspirin or steroids, and the crucial role of long-term secondary prophylaxis.
Yeah, the duration of prophylaxis based on carditis and residual disease is a common exam topic.
What's really striking looking back is how the body's immune system reacts to a common bacterium like strep A.
And ends up attacking its own tissues, the heart valves, the joints. It's a classic example of molecular mimicry, we think, where bacterial antigens resemble human tissues.
Yeah, that immune cross-reaction leading to such a complex systemic disease, it really underscores how intricate our immune system is and how it can sometimes, well, go wrong.
Precisely.
Okay, this deep dive should give you a really solid, high-yield overview for rheumatic fever. If you want more detailed information, practice questions, really hammer this home for the MSRA, definitely check out passthemera.com.
And for loads more free resources covering other MSRA topics too, head over to freemsra.com.
Good luck with all your studies. Remember, focusing on those core diagnostic criteria, the mnemonics, and the key management steps, especially prophylaxis, that's the way to go. And maybe a final thought to leave you with, just consider the profound impact that something as basic as consistently treating strep throat with antibiotics has had on preventing this potentially devastating condition in many parts of the world. It really highlights the incredible power of fundamental public health measures and accessible medical care.